Ray, thank you for that wonderful introduction. I hope I can live up to it. I want to thank DCU and Pieta for inviting me here today. It's when I kind of been here all day and listened to some of the conversations, presentations and discussions. You know, we've had really powerful conversations and discussions today, so I hope I can add a little bit to that. So just to introduce myself, I'm the nurse lead for the National Clinical Programme for Self-Harm and Suicide-Related Ideation, which is the HSE National Clinical Programme. So just to look at what I hope to cover today. Just to give you a bit of a background to the clinical programs, particularly our own clinical program, Self-Harm, looking at our vision and our objectives and tying that in with national policy and our own model of care. So then diving a bit more deeper into the program, looking at our clinical components and then focusing on our data and our data collection. And then looking at and that's going to be interweaved really with our two arms of our clinical program. One that is based in the emergency department that I will be just touching on, and the second that I'm going to go into a bit more in depth is our scan service for those presenting to primary care and the GP. So this is a bit of a busy slide, but for those that are not within the HSE, it kind of just puts it in a bit of context where our national clinical programs sit. So the CCO, the clinical office, so Dr. Colm Henry, you probably were familiar with Dr. Colm Henry's name through COVID. He would have had a lot of media presentations through COVID. So he sits at the top seat of that, and we have a number of different clinical programs right across the lifespan, diseases. So you can see there we have kind of acute mental health obviously sit there, primary care, older persons, chronic diseases. So we link with all of those clinical programs. So focusing more on mental health, we have a number of clinical programs within the mental health, and you see the word there, NCAGL, so it's that's the overarching governance of our clinical programs within mental health. And we were one of the first clinical programs to become established. And since then, the mental health NCAGL has really grown. You're looking at early intervention psychosis, eating disorders, and more recently then dual diagnosis, ADHD, and perinatal mental health. So then just onto our own clinical program. So our core team is very small, as you can see there, but compared to the other clinical programs, we are actually one of the biggest. So we have a part-time clinical lead. Our national clinical lead, Dr. Shane McInerney, works 2 days a week for the programme. He also is part of a community mental health team, so he's a general psychiatrist managing a busy community mental health team in an urban area. So he gives 2 days of his week to our clinical programme. We have Rona Jennings, our program manager. She is part-time to our program as well. She sits across 2 other clinical programs. We're very lucky to have Maeve Cosgrove, who is our database manager. She takes a lot of pride, very attention to detail in terms of the data collection and working with our nursing group. And myself, I'm full-time to the program. So just looking at our timeline. So we're one of the first established clinical programs for mental health, and it goes back to literature review and a scoping exercise back in 2012. So all that was done, there was a lot of research collected, and a model of care was developed back in 2014. With the model of care came funding. So the programme was very lucky to have a number of nurses funded, and they work across nationally, and they work in the emergency department. So they're mental health nurses funded by our programme through mental health services, and they work with their colleagues in the emergency department, their medical colleagues. And they see patients presenting in a mental health crisis. But particularly for our programme is people that present with self-harm or with suicidal ideation. And I'll talk a bit more of the process in terms of presenting a little bit later on. So with that establishment of nurses working nationally in the emergency department, there's that focus then on data collection. So in the early stages, data collection wasn't really robust. It was collected on a Word document, and then it developed into an Excel spreadsheet. So it was very rudimentary when it first started off. So then with the implementation of the programme, we had a number of governing body groups developed, and then back in 2018 we had a full-time data analyst appointed to the programme, as well as a nurse lead that would support the clinicians on the ground. So then coming up to date, we had a revised model of care back in 2022, and it really kind of expanded our service, and we brought under the auspice of the programme the scan service, so I'll touch on that in a little while. So just to really emphasise what the vision of the programme is. So it's to ensure that the clinical programme is embedded into everyday clinical practice, so that every individual who presents to general practice, emergency departments, community mental health teams, CAMs, following self-harm or suicide-related ideation, will receive a timely expert assessment of their needs and is connected to the appropriate next care, that the individual and their families are valued and supported by staff themselves who feel valued and supported. So that's really our overall vision of the programme. So just looking at our revised model of care, so this came into place in 2022. A lot of research and collaboration was put into developing in this document. And it really expanded on the work that was done in the emergency department and the research that went along with that. And we looked at incorporating supporting groups with specially identified needs. So we have sections on looking at the travelling community. I know it was mentioned earlier about physical needs of people. We also incorporated, the deaf community, people with chronic pain. So the programme really kind of expanded to look at those specially identified needs, and as well then the scan nurse service as well. So to put our model of care within the wider health policy context, it obviously is embedded in Connecting for Life, the HSE's national for suicide prevention. We have the Sharing the Vision, which is the mental health policy, and also Sláinte Care, so the right care in the right time, in the right place. So our programme really essentially has two arms of the programme. The long-established emergency department programme, and then more recently the primary care. So the overarching aim of the clinical programme is to standardise quality evidence practice across the mental health services, as I've mentioned in the vision. And it's to establish a clinical framework to ensure that there's a standard response to someone that is presenting with self-harm or with suicide-related ideation, that they will get a standard response wherever they present. So just looking at the four pillars of our clinical programme. The first one is response. So how is someone responded to when they come into the emergency department or come into any other aspects of our healthcare system? That they receive a compassionate, validating, empathetic response. And this goes across not just the mental health clinician, our clinical nurse specialist that's providing the assessment. We provide training to the emergency staff, so right the way through from our receptionists. So when someone clocks in and gives their initial details, that they receive a compassionate response, a validating and empathetic response from that moment. The assessment, that it is an expert biopsychosocial assessment. We have an expert intervention, so the nurses will work with that individual, providing a collaborative written safety plan. That the family carer, the supportive adult in that person's life, or the friend, next of kin, whoever that significant other is in their life, that they're involved in that assessment, that they're involved in that written safety plan. And they're involved all the way through, and it's a collaborative process. And that every person receives a follow-up and a bridge to the next care. We offer a 24-hour follow-up call to that person. So our programme is delivered in all Model 3 and 4 hospitals that have an emergency department open 24 hours a day. And we're really grateful to be in all 26 adult Irish hospitals. We offer our service in one paediatric Dublin hospital. And we have clinical leads, so that's consultant psychiatrists, leading and implementing the programme locally, and clinical nurse specialists. And we work with the wider liaison service as well, and we've a number of professionals working in that service that we link in with. And it's a multidisciplinary approach. I just kind of put this slide in very late, really, just to touch on the new HSE regions. And I suppose if you're not within the HSE, it's not the buzzword really, and what is everything, everything is spoken about in the HSE is about the change in the regions and how that's going to affect funding and things like that. But I said I'd just put it in there just to touch on it and acknowledge it. So just moving on to our data collection. So as mentioned, we established our data back in 2018, and we have a database manager, full-time database manager supporting that, which we're really, really grateful. But the people on the ground are collecting that data. So it's the clinical nurse specialists that are collecting that data in the emergency department and with the scan service, and they take a leading role in that. Our data is collected on a standardised data entry form embedded within an Excel document, which we know is not ideal. It's very time consuming for the clinicians trying to complete that. And I suppose it's important to mention that our data is focusing not on the wider, there's a number of people coming into the emergency department with a range of mental health crisis. We're focused on collecting the data of people that are referred to the programme, so that's people presenting with self-harm and suicide-related ideation. So the clinical nurse specialist line manager, the assistant director of nursing, would have a role in that in terms of looking at the quality of the data submission, that it is timely, it's collected a month in arrears, and our programme does a lot of training with our clinicians, our CNSs and line managers in terms of getting accurate data collection, timely submissions. So we do a lot of work with them. So just as I mentioned, we have been collecting the data since 2020. So it's on everyone that presents to the emergency department with self-harm and suicide-related ideation. And I suppose just separately from the NSRF data, we collect both self-harm and ideation, and I think the registry collect just the self-harm data. So just looking at the national metrics and KPIs really for our programme, and of those presenting that are assessed. So 95% of people presenting following self-harm or with suicide-related ideation will receive a biopsychosocial assessment. And that time to assessment, we try and aim to have 95% of patients assessed within 2 hours of referrals. It's a referral following their triage by a medical practitioner in the emergency department. And 100% of those assessments within 6 hours of the referral to mental health services. So just looking at the interventions received, and these are just for assessed patients only. So 95% of those will receive a full biopsychosocial assessment. Likewise, will receive a written emergency safety plan, and looking at the collaborative piece with the collateral history from the family members at 85%, and looking at 100% of the letters sent to the GP within a 24-hour period. So there's timely relaying of information back to the referrer. Family members and supportive carer involved, that 85% have a family member or supportive adult involved in their discharge planning. And 85% receive a follow-up call within 24 hours of discharge from the emergency department. And that patients discharged from the emergency department, 95% of them will be discharged less than 6 hours, and 100% for 9 hours, or they could be admitted as well. So just looking at the 5-year data report. So we had between 2018 and 2022, we had a report compiled by our previous database manager looking at our national figures. And between 2018 and 22, we had a total number of 72,126 presentations to the emergency department, and that 89 of those patients were assessed. And we found that approximately 50% came to the emergency department with ideation alone. And I suppose that brings me on to the next piece. So of those 50% of patients that came with ideation alone, in the absence of a physical act or a self-harm act, they didn't need to be seen in the emergency department. Now, we all know the emergency department is such a busy place, and if you don't need to be there, and when you experience a mental health crisis, it can be so overwhelming. So the program established and took under the auspice the Suicide Crisis Assessment Nurse Service. So what is that? It's a service that aims to provide a timely response to appropriate requests for assessment of patients in suicidal crisis from a named GP practice. So in essence, what is that? So it's a clinical nurse specialist funded by our programme and employed by mental health services locally that receives direct GP referrals from patients with suicidal ideation. So the GP picks up the phone, they do not make an e-referral or an email to the nurse, they actually pick up the phone and they talk to someone. There's a collaborative communication pathway between that nurse and the GP. There's a bias, so when the nurse has accepted the patient that they're for the scan service, the nurse completes a biopsychosocial assessment within 72 hours of having that referral. It could be a bit longer, but that's really at the discretion and the discussion between the patient and the GP and the nurse. So there is that bit of leeway, because people could be working and there's other nuances in their life that they might not be able to be seen within the 72 hours. So the CNS, following the assessment, would discuss the case with the GP. So it's done in collaboration with the GP, and they have clinical supervision from a consultant psychiatrist working in mental health services, and they supervise the practice as well and the assessment. There's also, looking at the pillars to the programme, there is an emergency safety plan developed in collaboration with the nurse, the GP and the patient. The nurse provides a written assessment, a completed written report, and that's given to the GP. The nurse also provides 3 follow-up contacts, so that could be face-to-face or telephone contacts. But the patient remains within primary care unless there is a formal need to refer them on to secondary care and their local mental health services. So just looking back at the history of SCAN and the early history there, it was first developed in Dublin, 5 minutes, okay, in 27, and then followed on the following year to Wexford. They developed it. So the service was evaluated back in 2012. NUIG undertook an evaluation of that. And by 2017, there was 13 SCAN nurses across 7 counties. Then NOSP carried out, commissioned by NOSP and carried out by the NSRF, there was another evaluation and report in 2019. And there was 20% coverage nationally by SCAN, wide variation in GP referrals, varied implementation of policies. There wasn't kind of governance in terms of a set pathway that they should follow. And around that time in 2017, referrals were looking at, there was 1,200 referrals to that. I'll move on. So just kind of the recommendations from those 2 reports were really that SCAN needed to be rolled out nationally, that GPs needed to support it, mental health services needed to support it, and there needed to be standard guidance and data in terms of the rollout. So that's really where our model of care and our expansion of our model of care in 2022, the service came under the auspice of our programme. So, and that's just the timeline. So it really builds on the 4 pillars, as I mentioned earlier, that compassionate, validating and empathetic response, the assessment, there's a full biopsychosocial assessment, and this could take a couple of hours. It's not just a quick assessment, it's a very, very in-depth assessment, giving that person that time to talk about what they need to talk about, why they're there. And it might have been the first time that they're in with a professional talking about what is going on for them, and they need that time and space to talk about it. There is the written safety plan. Family members are involved in that as much as they can, and there is that bridge to the next care, and they also receive the follow-up. Okay. So just looking at the national spread, you can see that there are large pockets nationally that don't have the service at all. So particularly in Dublin, we don't have any adult SCAN service. We have a CAMS, and it's the one and only CAMS service in North Dublin. But there is pockets within the Midwest, the whole of the Midwest doesn't have any SCAN service. Kerry doesn't have any SCAN service. So there's a lot of areas that do not have this service. Just to briefly mention, we are developing a cloud-based electronic data capturing management system called Caster, which is going to be rolled out to the emergency department. So we're in the middle of developing that. We're nearly ready to go live. We've had a pilot and we've had training around that. So once we have gathered all the information from the pilot, we will be able to start going live at the end of, or maybe even in the beginning of January, once we have all the nurses trained in collecting that. And it'll be the first collection nationally of the scan service. So we're really excited to be involved in that. The next step then for next year is to roll out the similar Caster data collection for the ED, and that will really support the nurses in collecting their data in the emergency department. So maybe just finishing up, my last slide is just looking at some of the challenges. So it's that data collection piece that hopefully we will start to go live now in January. So just building on that and looking at the teething problems with that. The fully implementing the scan service nationally, and that comes with funding. Looking at nursing career progression. At the moment, all the nurses are CNSs, so we're looking at the advanced nurse practitioner and having that clear nursing career progression to support the service. And we really need system-wide support for it to be fully implemented. So thank you.